Hello everyone. So today we're going to talk about HIV. HIV is a retrovirus. That means it replicates in a backward manner. Its genetic material is contained in a single strand of RNA instead of a double strand of DNA. There's increasing numbers of new HIV infections occurring in women, people of color, those who live in poverty, as well as young adults. So as for the case studies that you see, I'm not going to read through those, but I just do want to bring up a few things. So this gentleman here, he has gonorrhea. So does anybody recall what antibiotic is first-line treatment of gonorrhea? So the answer is ceftriaxone, 250 milligrams. The brand name is Rocephin. It is a cephalosporin antibiotic. If this gentleman was diagnosed with chlamydia, he would be given azithromycin 1 gram PO times 1 dose. Or another alternative, if he had an allergy to this, would be doxycycline. So with transmission of HIV, we discussed this back in pathophysiology. It is transmitted through blood, semen, vaginal secretions, perinatal transmissions during pregnancy, at delivery, and through breast milk. It's not transmitted by tears, saliva, respiratory droplets. So with sexual transmission, unprotected sex with an HIV-infected partner is the most common mode of transmission. Women are at a higher risk. I don't know if that's due to the fact that there could be some abuse there. Genital lesions from other sexually transmitted infections such as herpes or syphilis significantly increases the likelihood of transmission of HIV. So contact with blood. Sharing drug-using paraphernalia is highly risky, such as needles, syringes, straws. You might want to encourage the patient to consider participating in a needle exchange program. Also, puncture wounds are more common means of work-related HIV transmission through occupational exposure. Obviously, as nurses, there will be greater risk for this. There is 3 to 4 out of 1,000. So the risk is higher if the exposure involves blood from a patient with a high level of circulating HIV. A deep wound puncture, a needle with a hollow bore and visible blood, or a device used for venous or arterial access. So with perinatal transmission, it does have a greater risk for transmission to the fetus. It can also occur, as I mentioned earlier, during delivery of the baby or breastfeeding. As you see there, it does say an average of 25% of infants born to women with untreated HIV will contract the infection. So I want to talk a little bit about the pathophysiology. So to infect our cells, HIV must first bind to a cell surface receptor, and that is your CD4, as well as a co-receptor, such as a CCR5, and then it fuses with the cell membrane. HIV uses reverse transcriptase to convert its RNA into DNA and integrase to insert its DNA into humans. HIV uses protease to break down or to break large HIV polyproteins into their smaller functional forms. The principal targets of HIV are the CD4 T cells, which are also known as the helper T lymphocytes. And these cells are attacked by HIV because they carry CD4 proteins on their surface, thereby providing HIV a required point of attachment. Because of errors made by reverse transcriptase, HIV can mutate rapidly from a drug-sensitive form into a drug-resistant form. So if you turn to the slide, components of HIV, you see a little photo there, and you see that the HIV is surrounded by this envelope, and that's made up of some proteins known as GP120. So I'm going to turn the page here. So I already explained the HIV, how that proteins bind to the cell. Consequences of integrase. So the CD4 plus the T cells is destroyed after the HI virons are released. As for viral load in blood and CD4 T cell counts, HIV destroys about 1 billion CD4 T cells every day. For many years, the body can produce new CD4 T cells to replace the destroyed ones. But over time, the ability of HIV to destroy your CD4 plus the T cells exceeds the body's ability to replace them. And the decline in your CD4 plus the T cell count impairs that immune function, as you can see by the graph. So pathophysiology of HIV. So typically your immune problems begin when CD4 and the T cell counts drop to less than 500. Severe problems develop when there is less than 200 CD4 plus T cells, and the normal range is 800 to 1200 cells per unit liter. So later we're going to discuss some opportunic diseases, and the main cause of the disease is typically this. You also have disability, and then death occurs in patients with these opportunistic infections. A few we might discuss is toxoplasmosis, PCP. Patients can get esophageal candidias. Certain cancers, including Kaposi sarcoma, those are skin lesions that occur primarily in individuals with a compromised immune system. So slow-growing tumor appears as a raised, oblong, purplish, reddish brown lesions. They can be tender or non-tender, and organ involvement includes the lymph nodes, the lungs, the airway, the GI tract. It's just like essentially mouth to your anus. So anytime as looking at the case study here, things that you would expect is someone always to be tested for sexually transmitted infections. If they have a high-risk behavior, you want to ask about any known previous HIV infection. Discuss abstinence, using condoms. And also, they should not have intercourse when they do have a sexually transmitted infection. So some clinical manifestations and complications, typically that are evidenced at first, is a acute infection.
Hi.
Okay, goodbye. Okay, all right, that was nice of you.
My first time so.
Okay, so back to acute infections. Typically what the patient has first is kind of like flu-like symptoms. So your patient, they're going to have a fever, they're going to have lymphadenopathy, that's swollen lymph nodes. Maybe they're going to complain of a sore throat, a headache, muscle joint pain. Typically this occurs 2 to 4 weeks after. And during this time frame, the patient is highly infectious. So during this time, a high viral load, and the viral load is the amount of HIV circulating in the blood. And CD4 and T cell counts fall temporarily, but quickly return to baseline or near baseline levels. Patients can have an asymptomatic infection, and that's because most of the symptoms during early infection can be vague and nonspecific for HIV. People may not be aware that they are infected. Left untreated, a diagnosis of AIDS is made about 10 years after the initial HIV infections. And of course, patients may continue those high-risk behaviors and transmit the HIV to other people as well. Symptomatic infection, the CD4 and the T cells decline closer to 200 cells. Symptoms become worse. So patients have a persistent fever, frequent night sweats, chronic diarrhea, recurrent headaches, and severe fatigue may develop. And of course it says HIV advances to a more active stage. So flipping to the side, this is oral thrush. Patients, besides HIV, you find oral thrush in someone who is taking inhaled corticosteroids. This can also be caused by use of antibiotics because they kill that, good bacteria. So this is a common infection. It also can occur in the esophagus as well. This is pretty extreme from this picture. Typically what you see with a mild thrush case, the tongue might be a little bit, it looks yellow. You can also see a little bit of whitish yellow in the back of the throat along the tonsil area. So, and this is caused by Candida albicans. And typically, this can be a big problem in HIV-infected patients. Typically, if someone who does not have HIV, they can be treated with Miselex-Troche lozenges. Typically, the patient just uses it 5 times a day, let it melt in their mouth. You could also use what is called nystatin swish and swallow. So I usually tell the patient to make sure they swish it all around their mouth, and then sometimes I'll tell them too to gargle with it as well to make sure that they get that back in the throat. Clinical manifestations, complications, symptomatic infections, shingles, maybe persistent candidal infections, herpes, bacterial infections as well. So if you turn to the next slide, you will see a photo of a gentleman with Kaposi sarcoma. And so you see those vascular lesions. They can occur anywhere on the surface or as well as your internal organs. It's caused by the human herpes virus 8. Lesions can be pinpoint size to very large, as you can see in this photo. Oral hairy leukoplakia. This is an Epstein-Barr virus. It's painless, and you can see there the patient has these white raised lesions on the lateral aspect of the tongue. So with AIDS, the diagnostic criteria is established by the CDC. Immune system severely compromised. So you would expect infections. The patient at this point in time has opportunistic infections that we just went over. The CD4 and the T cell count is less than 200. Pneumocystitis jirovecii pneumonia. This is very fatal in AIDS patients. It's an opportunistic disease. This is considered to be a protozoan infection. And of course, it's a major source of mortality. Diagnostic studies, useful screening tests detect HIV-specific antibodies and or antigens. It can take several weeks to detect the antibodies. It's usually performed by using the patient's blood or their saliva. So HIV progression, it's monitored by the CD4 T cell counts, and as I mentioned, normal would be 800 to 12,000. Viral load, so the lower the viral load, the less active the disease. So the goal of treatment is to suppress the viral load to the lowest possible level, which is below the level of detection on a lab test or commercial assay. And this is often referred to as undetectable in the testing. So undetectable does not mean that the virus has been eliminated from the body or that individual can no longer transmit HIV to others. It's referring to the fact that the amount of circulating HIV in the blood is below the level of detection of the test. So typically what you can see in a CBC, you would expect the patient to have leukopenia, that's a low white blood cell count, thrombocytopenia, low platelets, anemia, typically that's associated with medications that the patient is specifically taking, such as antiretroviral therapy. As for labs, others you would expect to see an altered liver function, and that's caused by the HIV infection. It could also be due to the patient's drug therapy or a co-infection. Maybe the patient has hepatitis as well as HIV, and that's common. Let's see. So assays, they help HCP know which medication may be effective. So you have a genotype and a phenotype assay. It's similar to culture and sensitivity testing. It's also used for antibiotic selection. So interprofessional care. Before starting ART, you want to assess the patient's ability to follow a complex medication regimen. Otherwise, the medication will not be effective. So you need to evaluate the effectiveness of the antiretroviral therapy, or ART. So which laboratory test result will the nurse review? So what you want to look at is the viral load. So I'm going to skip over a few slides. So when we talk about goals of therapy, obviously your goals, you want to decrease that viral load. You want to increase the CD4 to T counts, decrease the risk of opportunistic diseases, and prevent HIV transmission. So safety alert, there are drug interactions that can cause hepatic and renal toxicity in HIV patients. So one that you need to be assured of is the patient is not taking St. John's worts. Other medication, over the counter, your PPIs, as well as your antacids. And also they can decrease the effect of the antiretroviral therapy. So with drug therapy and opportunistic diseases, prevention is key. So a number of opportunistic diseases associated with HIV can be delayed or prevented with adequate ART. Vaccines including hepatitis B, influenza, and pneumococcal vaccines, and disease-specific prevention measures. So with pre-exposure prophylaxis, this can be used in conjunction with proven prevention interventions, such as using condoms, like I mentioned earlier, risk reduction counseling, and regular HIV testing. Tenofovir, so that is spelled Tenofovir, in combination with, and I'll spell this, it's called emtricitabine. It's EMTRCITABINE. It's also known as Truvada, and it's used to reduce the risk of HIV infections in uninfected individuals who are at significant risk of acquiring HIV. And of course, one thing you always want to make sure that you, when we talk about assessment, is assess the patient's risk factors. At-risk patients, obviously anybody who is an IV drug user, ask about sharing needles. Ask about blood transfusions, especially before 1985. you want to talk about the patient's sexual experiences, vaginal, rectal. Has the patient ever had a sexually transmitted infection? So I'm going to skip over the goals. You guys can read that. So with the case study, where it says AO says he will not be abstinent, but is willing to use a condom during contact sex. What are the main points you need to cover when teaching about barrier methods of protection? Use only condoms made of latex or polyurethane. Store condoms in a cool, dry place. Protect them from trauma, and do not use them past the expiration date. Use only water-soluble lubricants with condoms. Place the condom on the erect penis before any contact is made with the partner's mouth, vagina, or the rectum. Hold the condom at the base of the penis and remove the penis and condom from the partner's body immediately after ejaculation, and dispose of the condom by removing it, wrapping it in a tissue, discard it, and of course never reuse condoms. So I am going to skip over some of this health promotion, where it says prevention of HIV, perinatal transmission. So ART has significantly decreased the risk for infants born to HIV-infected women, and more of these women are now becoming mothers. And obviously we've come a long way with therapy. So prevention of IV, decreasing risk at work. If you are accidentally stuck with a needle, typically I've seen more people complain of that they have stuck themselves with a patient who is combative or agitated. So if you do have a patient, always grab another person to help you and try to prevent that from happening. But if it does occur, you need to immediately report it. Don't wait to the end of your shift. Go to the ER right away. And of course, as you know, I've mentioned before, treat every patient the same, regardless of their background, race, ethnicity, age. So one thing, the case study, so it says, as you talk to AO about barrier methods of protection, he begins to look away, seems to lose interest. He says, I don't know if I can do this. So cultural considerations. So contraceptive can be a problematic for the Hispanic cultures, and that's due to religious prohibitions or the desire to have children. So ART can significantly slow HIV progression. Always make sure you tell the patient to report missing some doses of AZT. And of course, some of this therapy, the medications, they may have to take up to 3 to 5 medications, and some of these medications are taken, you have to take them 5 times a day. So they really have to be compliant with that regimen. So with some of the drugs, you guys don't have these notes. You have nucleoside reverse transcriptase inhibitors. That's referred to as NRTI. There's also non-nucleotide reverse transcriptase. That's referred to as NNRTI. And they block the action of reverse transcriptase in order to prevent the virus from converting to a double-strand DNA. If the virus is not stopped here, then the virus needs the enzyme integrase. So the next class would be integrase inhibitors. And these help it to integrate itself into the nucleus of the cell. In order for the virus to mature and go on to infect the next cell, it requires the enzyme protease, which is where the meds called protease inhibitors work. And they interfere with the ability of the virus to mature and infect other cells. So at this point, the T helper cell is infected, and each time that the cell replicates, those cells are infected and the virus is free again to move on and infect the next cell. So again, missing doses can lead to drug resistance. Nursing interventions should support teaching or making changes in the patient's drug schedule. So ultimately, to prevent drug resistance, the patient has to be compliant. And of course, adherence to drug regimens, it's critical to prevent disease progression, opportunistic disease, and viral drug resistance. So supporting a healthy immune system, vitamins. Maybe the patient needs to go to a dietitian, drink Ensure, make sure that they're receiving their vaccinations, pneumonia, influenza. They need plenty of sleep, reduce stress, avoid unprotected sex. So with the case study, he tells you he really cares about one of his partners. What do you tell him? So with this patient, you want to encourage him to tell his sexual partners about his gonorrhea. And gonorrhea is often asymptomatic in women, and it can cause infertility as well in women. Male partners should be treated. This is a reportable disease to the health department. Moving on. And of course, the health department cannot give out your name. They can contact the patient's partners if he goes ahead and gives them a list of names. So acute exacerbations, obviously you know there is no cure. Patients have this for life. The best way to prevent opportunistic disease is to assure the patient is adhering to effective ART regimen. So metabolic disorders, some HIV-infected patients, especially those who have been infected and are on ART for a long time, they may develop a set of metabolic disorders there. You can read through those. Bone disease, that can be improved with exercise, dietary changes, calcium, plus your vitamin D supplements. If you turn to the next page, you'll see this patient. It's a female with a lipodystrophy. That's when you have changes in the body shape. It causes redistribution of fat in the abdomen, the upper back, the breasts, along with fat loss in the arms, legs, and the face. So this metabolic disorder obviously needs to be managed. Let's see. So this case study now, his CD4 lymphocyte count is 76. He's lost 13 pounds the last month, positive PPD. What do you think is happening? He has an opportunistic infection and is likely HIV positive. Indications are Mycobacterium tuberculosis. So you would want to ask about night sweats, productive cough, weight loss, history of a positive PPD. End of life care, expect shortness of breath, pain, restlessness. For your geriatric patients, these patients are less likely to come forward if they do have a sexually transmitted infection, because they don't want to talk about it and they're embarrassed. And of course they are maybe hesitant to tell their families. But you need to keep in mind that the elderly population are still promiscuous. Also, other things you can do is consult hospice if the patient has a life expectancy of 6 months. I'm going to skip over these audience response questions. The test grades, they look really good. I'm proud of you guys. So I will upload this as soon as I can, and I hope everybody is doing well. Goodbye.